Bismillah ar-Rahman ar-Rahim, starting by the name of God, the compassionate, the most merciful. Today I'll be talking about the ECG basics, and I can promise that by the end of this video you have mastered all the ECG basics and essential information that you need. And in another word, I can also say that this video is kinda like a summary of the first 100 pages of the only ECG book you will ever need. There's such a book, you can check it up. It's the best ECG book I've ever read, and I can say that this video acts like a summary of the first 100 pages of that particular book. Nevertheless, I've taken many other information from other resources as well. So, nevertheless, let's start the discussion. First of all, I want to say that in this presentation, I will underline the following: the cardiac conduction system, the leads, ECG paper, as well as heart rate calculation, both in case of regular and irregular, ECG components, and axis deviation by the end of the video. So let's start with the types of cardiac cells that we have. The first type of cells we have called pacemaker cells. And remember, under normal circumstances, they act like the electrical power source of the heart. But remember this word, and under normal circumstances, because we have some sort of pathologies, such as ectopic beats, where they do not originate from the pacemaker cells. In another word, if you take any type of cardiac cells, they have the capability of generating electrical impulses. But under normal circumstances, it only happens in pacemaker cells. And the pacemaker cells, for example, we can find them in the nodes, like SA nodes. The second type of cell we have is called electrical conducting cells. These are the hard wiring of the heart. In another word, if you have conduction system uh, like forming generation of electricity in the pacemaker cells, then you need something for this electricity to conduct through. And this happens in these cells. So they act like wires. And the third is the myocardial cells, where the contraction takes place, or in another word, they are responsible for contraction. Once they get electrical impulses from the wire cells that was generated first of all in the pacemaker cells. So I hope everything makes sense, and let's move forward now. Let's talk about the conduction system itself. The conduction system grossly is made of the SA node, which stands for sinoatrial node, atrioventricular node, AV node, bundle of His, the left and right bundle branches, and it ends in the Purkinje fibers, terminal Purkinje fibers. But between them, we have some sort of other pathways which are normally exist. Between the SA node to AV node, we have internodal pathways in the right atrium, because SA node normally located on the right atrium. So how does from the right atrium electricity can move to the left atrium? That happens through the Bachman's bundle, and you can remember this name but like Batman's bundle. They're close to each other. So once the right atrium starts depolarizing from the SA node, in the meantime, left atrium is getting depolarized as well through Bachman's bundle. So remember that. Now let's move to the AV node, and AV node acts like a kind of barrier. It delays the conduction between the SA to the bundle of His. And we will talk about the benefit of this delay later. Then we have the bundle of His. Bundle of His divides into left and right, but be careful. The right bundle branch is simple. We just have the right. But in case of left bundle branch, it further classifies into three other fascicles. Here I have shown this in the right side of the slide. We can see that the left bundle branch divides into the left anterior fascicle, the septal fascicle, and the posterior fascicle. So the septal fascicle itself play a major role, which we're going to talk about it later. But remember something, that when electricity comes from the bundle of His, first it go to the left bundle, and at first, to be more precise, it go to the septal fascicle. This is the first fascicle that gets depolarized before the other fascicles. So just keep this in mind. Later we will see why we need this. And now let's talk about the leads. That was almost everything about the contact system. Later I will talk about it with the ECG components, the rest that's left to talk about. About the leads, remember in total we put 10 leads on the body of the patient, but actually we see 12 leads on on the ECG paper. And how does this happen? I will explain it. First of all, we have two types of lead. One is called the limb leads, the one we put it on the limbs of the patient, and one is called the chest leads, or we also call it precordial leads. We put it on the patient's chest. And now talking about the limb leads, remember that in case of the colors is quite variable. So you have to check which colors do you use in your country, because in my country we use yellow in left arm, we use green in left leg, we use red in right arm, and we use black in right leg. But it can be variable, so you have to check it out by yourself. But nevertheless, in case of the places we put them on the wrist of the hand and also the ankle of the legs. We have 4 leads, and the one on the right leg, which mostly represented by a black color, it does not give any sort of benefit to the ECG. Like, I mean, in a case of interpretation, you cannot see it on the ECG paper. It only acts like a ground base lead that can reduces some signals that interfering with the ECG machine. So it only helps to improve the quality of the ECG, nothing else. So we only work with right arm, left arm, and left leg. That's why we have this triangle of Inthofen. Inthofen was one of the scientists that made this triangle, which I will explain it in the next slide. And as for the chest leads, anatomically, remember, we put the V1 on the right side of the sternum on fourth intercostal space. We put V2 on the fourth intercostal space on the left sternal angle, as you can see in the picture. Then you will not put on the third lead. You will move to the fourth lead first. You will put it on the fifth intercostal space in mid-clavicular line. Then you will come back to V3 and you will put it between V2 and V4. So in this way, you will avoid any sort of confusion. Then you will put V5 on the anterior axillary line and in the same horizontal line of V4. Then you will put V6 in mid-axillary line, and in some cases, especially in case of posterior myocardial infarction, we're gonna need some posterior leads, which we don't attach it to the patient in normal circumstances. And those leads are called C7, C8, and C9. So you will just move in the same horizontal line to backward. So C7, you will put it in posterior axillary line. C8, you will put it in mid-scapular line. And C9 you will put it on paraspinal line. So you can check out the lines by yourself, but for now it's all we need. Now let's move on and let's see how these leads that we put it on the patient, how these leads are interpreted on the ECG. So first of all, we're gonna need something that lead 1, 2, and 3, they are called bipolar leads. Whereas leads AVF, AVL, and AVR, they are called monopolar or augmented leads. And I will explain it why. Lead 1 and 2 and 3, they are called bipolar because they are moving from a negative electrode to a positive electrode. So they are bipolar. And lead 1, remember, it's made from the right arm to the left arm, and it always moves from negative to positive. Always the arrow will move from negative to positive. That's why you have a lead 1 moving this way. I will explain it in the next slide about the degrees, but just for now, get the main idea how these leads are formed. Then lead 2 is made with the right arm with the left leg. And again, it's negative, moving to positive. And lead 3 is made between the left arm as well as the left leg. That's why I'm moving in this direction. And when it comes to AVF, AVL, and AVR, remember these ones are different. For example, we have the AVF, and remember the letters F. Remember it like in case of inferior because it's in the inferior. L for left, remember it. R for right side. So in case of AVF, just take the inferior side and take an average of the other two leads. For example, we take AVF on the left leg and take an average of the right and left arms. The average will be the center. So if you take the center and you move to the AVF, that will make the lead AVF on the ECG. Now this time let's take AVL, L for left arm. Take left arm as an example and take the average of the other two. For example, other two will be right arm and left leg. The average will be on the center. If you take from the center to the left arm, it will form AVL, and the same thing for AVR. We will take the right side, the average of the other two, then we will move to the right side, it will form AVR. And now in the next picture, we can see it even in a more clear format that this lead 1 that we talked about it, let's go back to lead 1, you see from right arm to left arm. So if we count that the patient is right arm is here and left arm is here, the lead 1 have a 0 degree because totally horizontal. I hope that's clear. And now if you go back to lead 2, from right arm to left leg, if we put it on the degrees, it will make a plus 60 degree. And if we go to lead 3, left arm to left leg, it will make a positive 120 degree. I hope that's crystal clear. And now let's move on to the other three leads, which we have AVF, AVL, and AVR. Just take a look at them, how we formed them, and now look at them on the axis. On the axis, AVF has a plus 90, AVL has a minus 30, whereas AVR is minus 150. We're gonna need these degrees later, so you really have to memorize them, but somehow I explained it in a logical way that you can remember it without memorization, but the degree itself kinda you have to memorize it. And now I can even summarize it into the anatomical sites that they look at the heart. First of all, remember, if we combine all these 6 leads that we talked about it, from lead 1 to 3 and from AVF to AVR, we can call all the 6 leads the frontal leads, but because they look at the heart from a frontal point of view. In another word, they talk about up, down, left or right of the heart. Whereas the chest leads, they talk about horizontal part of the heart. And for this case, I have found a website where we can see it in a 3D format. And now let's move to the 3D format. So now, as you can see, now this is the heart. This is the right atrium, right ventricle, left atrium, left ventricle, and this is the aorta. So what we need to do is, for example, let's forget about the chest lead at the moment because we were talking about the frontal leads. The frontal leads, lead 1, 2, 3, AVF, AVL, and AVR. I said they look at the heart from a frontal point of view, and we talk about whether it's on the upper side, lower side, or right or left. So now let's take the lower side of the heart. The lower or the inferior side of inferior wall of the heart is represented by 3 leads. They are lead 2, lead 3, and AVF. Do you remember the angles? Lead 2 plus 60, lead 3 plus 120, lead AVF plus 90. So they look at the heart from an inferior side. That's why if you have any changes in these 3 leads, you will say we have some sort of defect in the inferior wall of the heart. That's how you make sense out of ECG. Now let's move on to the left lateral side. On left lateral side, at the moment we have, for frontal leads, we have AVL and lead 1. They look at the heart from the left side. That's why if you have any changes in these two leads, the left side of the heart is, there's some sort of pathology there. And IVR is looking at the heart from the right side. So I hope we made that clear. And now let's come to the chest leads. In case of chest leads, if the other leads are called frontal leads, this one is called transverse or horizontal leads because they look at the heart from a horizontal point of view. It does not talk about left and right, up or down. They talk about it like horizontally. It's like it's like you have a piece of meat and you're slicing a knife through it. This is the same for the chest leads. And remember, for the chest leads, we mainly talk about their position, where they located. For example, as you can see, V1 is more located on the right side of the heart. That's why it's more specific to the right side of the heart. Whereas V2, V3, and V4, they are more located in the anterior septum of the heart. The anterior and the septum of the heart. Here is the septum of the heart. So, whereas V5 and V6, they are more located on the left side of the heart. So, now let's combine all the leads together this time. For example, if I tell me the leads of the left side of the heart, which leads you will tell me? Of course, you'll move to this side. You will say AVL lead 1 and V5 and V6 as well. They look at the heart from a left lateral side. Okay, now let me ask you which leads are looking at the heart from inferior side. This will be the leads 2, 3, AVF. And we have AVR looking at the right side of the heart. Sometimes you can combine it with V1, but nevertheless, AVR is, it's like, we call it like an independent lead. It's really independent from the other leads, so it's better not to combine it with any other lead. And when it comes to the rest, there are some resources that tell that V1 to V4, they look at the heart from anterior septum, but actually we can separate V1 more to the right side of the heart and V2, V3, V4 more to the anterior septum, and we will see why in just a minute. And now what we talked about, let's make one summary again. Lateral leads, lead 1, AVL, V5, V6, inferior leads, lead 2, 3, AVF, anterior septal leads, V1 to V4, but as we said, V1 is more of the right side. And in case of the blood supply, all of the sides of the heart have its own blood supply. Remember, the lateral leads are more supplied by the left circumflex or diagonal branches of left anterior descending artery. In another word, we have the left side of the heart, and the anterior side is supplied by the left coronary artery. And left coronary artery further classifies into different arteries. But remember, for left lateral, most of the time is left circumflex artery, and I will talk about this in the next slide, but nevertheless, let's talk about it here as well. In case of inferior leads, we have, it can be right coronary artery or left coronary artery. I will explain that in the next slide. And in case of the anterior and septal, we also have some variation, which I will explain it now. But what I wanted to draw your attention to was this picture. This is an ECG picture, but we kind of paint it. And the reason is to tell you that this lead 1, lead 2, lead 3, AVR, AVL, AVF, and lead V1 to V6. So please remember, lead 1, AVL, V5, V6, they relate to the left lateral side of the heart, V1 to V4 anterior septal, whereas 2, 3, and AVF to the inferior side of the heart. I hope that's crystal clear. And now in case of the blood supply, remember something, there's the left coronary artery. It divides into left anterior descending artery and the left circumflex artery, and the left anterior descending artery has some other branches like the diagonal branches, but this is not so high yield. You just need to know the main artery. And whereas the right side is right coronary artery, then we have the right marginal artery, and we can have posterior descending artery from the right coronary artery as well, but I will explain it now. Remember something. First of all, in case of the conduction system also needs blood supply. The SA node, AV node, everything that we talk about, and especially we're going to talk about SA and AV node because these are the most important nodes because they can beat at a higher rate comparing to other. For example, SA node can fire electricity between 60 to 100 beats normally. AV node around 40 to 60 beats. But bundle of Fs and others, they are lesser that the patient cannot stay alive based on them. But nevertheless, for what we need at the moment is, in case of the blood supply to the SA node, in 60% of the population, of human population, it's supplied by the right coronary artery. In other words, if you have a problem with the right coronary artery, let's say there is atherosclerosis and there is no blood flow, in 60% of the people there will be no blood supply to SA node, and it will cause problems. Whereas only in 40% of the people is supplied by left coronary artery, and especially a branch of left circumflex artery. So it's variable. It's not like something specific to every humankind. It's totally variable. Whereas in case of AV node, 80% is supplied by right coronary artery, and only 20% is supplied by left coronary artery. By the way, there is something that I want to avoid, a kind of confusion. When I talk about, for example, in case of this blood supplies, I don't mean that, for example, AV node 80% is supplied by right coronary artery and the rest is supplied by left. No. What I mean in 80% of population, AV node is totally supplied by right coronary artery and vice versa. So please avoid that confusion. And now we have something else also called, is the patient right dominant or left dominant or codominant? You might have heard of this. The main thing is that determines whether the patient right, left, or co is to look at the posterior descending artery. This artery that's here. This artery. In case of posterior descending artery, if it branches off the right coronary artery, then we call it right dominant. If it branches from the left coronary artery, we call it left dominant. If it branches from both of them, we call it codominant. But mainly in 85% of the population, it branches from the right coronary artery. 10 left coronary artery, and 5% of the population from both sides. I hope that's clear. Now let's move on, and now we will explain the ECG paper. First of all, we have to know something. The ECG has a vertical axis as well as a horizontal axis. The vertical axis we will count it with millivolts and sometimes with millimeter as well. We can just, I will summarize it later. And in case of horizontal, we use seconds, and sometimes they use milliseconds. So it depends on your country and which one the doctors around you are using. So each ECG paper has big boxes and small boxes. Remember something, that each small box, these ones we talk about, represent 0.04 seconds. Whereas each large box represents 0.2 seconds. And if you want to make sense out of this, we have 5 small boxes in one large box. If each small box is 0.04 second, then multiplied by 5, it will be 0.2 second. I hope we made that clear. And when it comes to 1 second, we can count how many large boxes it will be equal to 1 second. If we have one large box, 0.2 second, then multiplying it by 5, it will be equal to 1 second. So 5 large box on the ECG is equal to 1 second. I hope that's clear. And when it comes to the amplitude, we have to remember that uh, the amplitude is about the strength of the electrical impulses that are moving through the ECG paper, whereas the speed, I mean the caliber. We have two things on the ECGs that we really have to look at them before reading any type of ECGs. We have something called the caliber, like this one in the picture, and we have something called speed. And mainly the normal, the caliber should be on 10 millivolts, whereas the speed should be on 25 millimeter per second. And this will be written on the ECG paper, the ECG machine. You will choose it by yourself. But the standard are 25 and 10 millivolts. So 10 millivolt, each small box represent 0.1 millivolt. So if you have 10 small box, it represents 1 millivolt. That's why we should have an amplitude of 1 millivolt for the caliber, but we call it 10 millimeter because the millimeter stands for the small boxes. Like each small box is a millimeter. That's why let's just summarize it so we will keep it in a simple format. Each caliber should be 10 millimeter, or in another word, it should be 1 millivolt, whereas the speed should be 25. If the speed is 50, everything changes. For example, if one small box was 0.04 second, in case of 50, an ECG that was recorded on 50 millimeter per second, it will be 0.02 second. So everything changed. But to avoid this confusion, we will only stick to the standard, and I will make another separate video on the ECGs that are recorded on 50 millimeter per second. Nevertheless, let's move on. And now let's talk about the heart rate calculation. First of all, before calculating the heart rate, you have to ask a question. Is the heart rate, is the ECG strips that you have in front of you regular or irregular? And how do you determine that? In case of regularity, you just have to look at the RR. For example, there's a QRS complex, there's another QRS complex, and these two together, they are called RR interval, the interval between two R waves. So the interval between these two should be equal to the next RR interval, and so on and so forth. For example, let's count this one. This is almost equal to 4 large boxes. You'll take the tip of the R wave, by the way. There's a one missing small box, but for the sake of the argument, we will just count it as 4 large boxes. Let's now measure this one, 1, 2, 3, 4 as well. This one, 1, 2, 3, 4. So now we decide that this one has a regular rhythm. It beats regularly on a regular pattern. So next time, how do you calculate the heart rate will be according to this formula. The formula tells us that you will take the number 300 and you will divide it by the amount of large boxes between two RR interval. So in another word, in this case, we have 4 large boxes. So you will divide 300 by 4 large boxes. So 300 divided by 4 will be equal to 75. So this patient's heart rate is 75 beats per minute. So this is about the heart rate calculation, and there's this simple way you can remember. If there's one large box between 2R, it is equal to 300. 2 large boxes, it will be 150. 3 large boxes will be 100, and so on and so forth. So you can just remember this, because most of the ECGs, if they have a regular rhythm, it will be in this distance where there's 5, 4, 3, and between that. And especially you will see 4 a lot. Nevertheless, this was about large boxes, but what if you take the small boxes? The small boxes actually are more accurate. For example, in this case, I didn't count this one, this small box. But if you want to be so in detail and in precise, you will take 1500 divided by the amount of small boxes between two QRS complex, which is the RR interval, and you will get the exact precise number of the heart rate. Nevertheless, Let's move on. Now, what if you have a heart, an irregular rhythm? By irregular, we mean that, for instance, if you look at the distance between QRS complex 1 and 2, it's not equal to the 4 and 5th or third and fourth. So there's a variability between them, and this is called irregular rhythm. For this, I have brought two rules. One of them is official and standard. You can use it without any fear, but the other one is easier, but it's not so accurate. Let's start with the rule of six. What do you mean by the rule of six? The rule of six tells us that you have to count the large boxes that represent 6 seconds. And 6 seconds, if we said that 5 large boxes is equal to 1 second. So 6 seconds represented by 30 large boxes, as you can see it here. So in case of the 30 large boxes, you will count how many QRS complexes are seen. For example, this ECG strip that I have brought it here from here to the end is made of 30 large boxes. So we will not count it and waste time on it. So how many QRS complexes you see here? 10. Then you will multiply this 10 by 10. It will be 100. So the heart rate of this patient is 100. In another word, I'm repeating it again. You will count 30 large boxes. How many QRS complexes you will see, you will multiply it by 10. The number 10 is not changed at all. It's a fixed number. But there is another rule, uh, which is called the rule of 3 seconds. You will count 3 seconds. 3 seconds will be 15 large boxes. Let's count it. But you will multiply it by 20. The 20 is also a fixed number. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So 15 large boxes, we see 5 QRS complexes. 5 multiplied by 20 is 100. The same result of the standard rule, 6 seconds. So in this case, it worked out. But there was some cases that I did it by myself and it didn't work out. So it's not so reliable, but nevertheless, in case of some sort of emergency, maybe you can use the rule of 3 seconds. So I hope that's clear. And now let's talk about a bit of conduction system again, and we will move to the ECG components. There's something that I want everyone to keep it on mind. In case of depolarization, for example, if we have, let me bring the pen, we have the electrode here, okay? By the way, there was something that we have to differentiate between them. I guess I even confused it in the beginning. I forgot to tell that. Those things that we attach to the patient's body are called electrode. But their representation on the ECG is called leads. For example, we can have lead 1, 2, 3, AVF, and all those leads that we studied. These are the leads on the ECG. But the device you will put it on the patient is called electrode. So sorry for that. So if we have the electrode here, okay, and depolarization happens on the same side of the electrode. I mean, it goes towards the electrode. And normally, inside the cardiac cells, they are all negative. When depolarization happens, inside will be positive, outside will be negative, as is shown in this picture. When depolarization happens and goes in the same direction of the electrode, you will see a positive deflection on the ECG. That's why you see this line. So the depolarization continued in the second picture. Sorry, this one is going in another direction. If it continues, you can see it here, for example. It will go up and go down again, and I will explain why it happens. But before that, we have to know something. When in depolarization, when it go in the same direction of the electrode, it will deflect a positive deflection on the ECG. But if it goes away from it, it will have a negative deflection. But what if the lead is located between them? For example, in this case, the lead is here, depolarization go in this side, in this direction. At first, it's getting closer to the electrode. but later it moves away from the electrode. So how can we interpret this one? Actually, it's easy. We can just use logic. Once it's getting closer to the electrode, it makes a positive wave. Once it reaches the same position of the electrode, it will come back to the isoelectric line, to normal. Once it goes away from it, it will become negative. And at the end of the depolarization, it comes back to the isoelectric line as well. That's why you see this picture here. This is the end of the depolarization. I hope that's clear. And this picture as well, on this side, the depolarization is going away from the electrode. That's why you have a negative deflection. And that helps us a lot later when we're gonna explain some other features of ECG. Let's move on. Uh, in case of now, let's talk about the conduction system that starts from SA node and is located in the atria. In another word, the atrium is the atria, the both of them, the right and left, are the ones that are getting depolarized first. And how do we see this on the ECG? It's represented by the P wave. P wave is a representative of atrial depolarization. And for each wave, we have two things. One is duration, one is amplitude. The duration of P wave should be between 0.06 to 0.12 seconds. And the amplitude should be between 1 to 3 millim. But I've made something that you can remember it easily. The rule of 2.5 by 2.5. In another word, if you have a ECG, the large box, we should have 1, 2, 3, 4, and 5. Okay. And here as well, we're gonna have 5 again. Sorry for my handwriting, but nevertheless, we just need to understand this. Remember that the P wave will have an amplitude and duration of not more than 2.5. In another word, if there's 2.5, it will be like this. So from here to here, it should be 2.5 small box, in another word. I hope we made that clear. And about the P wave itself, it should be smooth, like in this picture, and it should be round. That's a normal P wave. Please do not confuse it with the atrial flutter waves, the F waves. They do not have this smooth and round uh, look. That's how you differentiate P wave from other uh, fibrillatory or flutter waves. And remember something else, which you don't see it most of the time. I don't know why they don't explain this, but the first part of P wave represents the right atrial depolarization, whereas the left side of the P wave represents the left atrial depolarization. And that helps us a lot later in in the next videos how, in case of atrial hypertrophy. For example, I can just tell you something. If you have a left atrial hypertrophy, you're going to have problem with the second part of the of the P wave. It will be something like that. For example, first part is normal, but the second part, because there's a hypertrophy, there's more electrical impulses going there. That's why you can see another rise of the P wave. That's why we can see that's the left atrial hypertrophy. But if there's a problem with the first part going higher than normal, we can see that's the problem with right atrium. That's how, you know, ECG, you can just make sense out of it if you know the concepts. So I hope that's clear, and now let's move forward. And remember that for everything we have something called vector. Vector is the strength and the direction of the impulses that are made in that particular region. For example, in case of the atrial depolarization, the mean vector, the mean, if you take all the vector, for example, one vector moving this side, one moving this side, so in this direction, if we take all of them and only draw one that's an average, that's a mean to all of them, it will be in this direction as it's shown in the picture. So that's the mean vector of P wave, and it's between 0 to 70 degree. And how does it help us? It helps us on the leads. For example, now, if you remember, we said lead 1 is 0, lead 3 is 120, and lead AVR is minus 150. If we take these three leads from the frontal leads, okay, we have a lead 1. The vector is getting closer to the lead 1. And we talked about, in case of depolarization, if the vector, the depolarization is going the same direction of the lead, it shows as a positive deflection. That's why you see a positive P wave. But in case of AVR is behind there, and this one is going away from it. That's why in AVR you always see a negative P, negative QRS, negative T as well. So that's the main idea behind it. But in case of lead 3, always remember we said if the lead is perpendicular, for example, this one is going this direction and lead 3 is perpendicular to this direction, then you will, once it's getting closer to lead 3, it makes a positive deflection. Once it's going away from lead 3, it makes a negative deflection. That's why you have something called biphasic P wave, which is shown here in lead 3. So this is about the frontal leads. What about the chest leads? The precordial leads, V1 to V6, we'll just take V1 and V6. V6 is almost, by the way, V6, the precordial leads, they do not have axis because they are looking at the heart from a horizontal point of view. They have a fixed point on the heart. They do not withhold an axis as they do in the limb leads. That's why we are just talking about that. V6 is on the left lateral side of the heart, and this vector is kind of going this direction. That's why in V6 you always see positive P wave, but in V1 it's on the right side of the heart. It's kind of like lead 3, but be careful again. There, I explained it in the 3D leads that they are looking at different angles of the heart, even though in this case they look like to be the same. So I hope the point is clear, and here we have a biphasic as well. So let's move on. There's something to remember. This example I gave here, it's not the same always. People are individuals. We can have different positions and lines of the heart. For example, if normally, let's say a patient's heart is in this position, but it changes to this position, there's a, let's say, a rotation of the heart in the chest. So it changes all the electrical values that we have on our brain. That's why you cannot stick to these. These are just standards, but they are not fixed. For example, in lead 3, we said we see a biphasic P wave, but it's totally normal to see a negative P wave or a positive P wave in case of some individuals, and it's normal. You will not say it's abnormal, and it comes to experience with that. You will, in case of negative P wave, later you will determine it. How is it abnormal? How is it normal? This for future videos. Now we are just talking about the basics. Nevertheless, after P wave, we have the P wave. We have a stop for isoelectric line is in the same size. Then we have the QRS complex. Okay, but before the QRS complex, we have this straight line. What does it present? It presents the AV node. Do you remember? I said between the atrium and the ventricle, the SA node and the bundle of his, we have AV node that delays the conduction. And the main idea is it's a physiological delay in conduction that's essential to allow the atria to finish contracting before the ventricles begin to contract. So it's really, we really need this normally. That's why you see this straight line here. That's represented by the AV node. So AV node is neither a part of atrial depolarization nor ventricular depolarization. Is independent, and it's represented by this straight line. Next, let's talk about PR interval. PR interval starts from the start of P wave and ends with the start of QRS complex. And normally the duration of this should be between 0.12 to zero point 0.2 seconds, which are represented by 3 to 5 millimeter. By the way, when I say millimeter, it represents small boxes. So 3 to 5 small boxes represents the normal PR interval. By the way, someone might ask, what's the amplitude of PR interval? That's wrong. When we talk about interval, we only talk about time. When we talk about segment, we talk about elevation and depression. So always remember this. Interval talks about time, segment talk about elevation and depression. So normal amount of PR interval represented by 3 to 5 small boxes, and it represents the time from the start of atrial depolarization to the start of ventricular depolarization. So but remember something, it also includes the delay in AV node. So it includes SA node and AV node as well, both of them. That's why if you have a AV block, what do you see? A prolonged PR interval. Why? Because PR interval includes both of them, SA node and AV node. I hope that's clear. And now also let's talk about the PR segment. The PR segment represents the time from the end of atrial depolarization to the beginning of ventricular depolarization. So you will count from here to here, and you will look at the isoelectric line. By the way, isoelectric line is the line that starts even before the P wave. So this is the isoelectric line. Is the PR segment in the same line? Yes, so it's normal. If it's elevated, if the line was like this, let's say this is a P wave, but the line is now here, and now we have the QRS complex and T wave. So the line elevated, there's a problem. And mainly we can see depression of the PR segment in case of pericarditis, for example. You see a depressed PR segment. So this is about PR segment as well. Let's move forward. Now let's talk about ventricular depolarization. First of all, you have to know it includes 3 parts: bundle of V's, bundle branches, terminal Purkinje fibers. They represent ventricular depolarization. Please do not confuse it again. It does not include AV node. AV node is for PR interval. In these 3 are representing ventricular depolarization. And how do we see ventricular depolarization on the ECG? We see it on QRS complex. In another word, QRS complex represents ventricular depolarization. What's the normal duration? 0.06 to 0.1 second, which we can say that it should be less than 2.5 small boxes. For example, here we have 2 small boxes of QRS complex, and it's normal too small. Do we talk about the amplitude? Yes, we do talk about it, but not normally. When you see an abnormally high QRS complex, then you will think of hypertrophy. But normally we do not count it. It does not give so much high yield points to us in case of interpretation, except of the hypertrophy. That's why we only talk about the amplitude of hypertrophy in detail and its criteria in case of left and right ventricular hypertrophy. So I will not waste time here with QRS complex amplitude. I hope that's clear. Now again, before talking about the vector of QRS complex, vector of ventricular depolarization, I want to talk about some formats of QRS complex that can present. Remember, after P wave and the AV straight line, anything that comes as a negative deflection is called Q wave. Anything, the first negative deflection is always called Q wave. This is negative, Q wave. This is negative, and the beginning Q wave here as well. And anything that comes even in the beginning or later doesn't matter. If it has a positive deflection, like in this case, it's called the R wave. This R wave, and even this one is R wave as well, because it's going up. R wave here as well, R wave, R wave, and this one you will not call it R wave because it's still in negative side. And anything that comes after a positive deflection and itself is negative is called S wave. This is a negative deflection that came after a positive deflection. So this is called S wave. S wave. And we have S wave here as well. So now let's make sense of all of this together. If you have this one, this is called QRS. This is a normal QRS we are talking about. But this one is only called RS. We have positive and negative. This one, both of them are negative. The first part is Q, the next part is S. We call it QS. This one is a bit tricky. We can see it especially in lead V1 in case of right ventricular hypertrophy. You will see this M-shaped QRS complex, and this one is called RSR prime. This number 1 stands for the word prime, like primary. It's like the first, so that's why they give this number 1, RSR prime. And we said that's the R, and any negative deflection after a positive deflection, we said it's called S. That's why this one is S, then another R, and coming back to isoelectric line. This is not S. This is just coming back to isoelectric line at the end of the depolarization. That's why it's called RSR prime. So this one is QR, this one is only R. We don't have S. Be careful of that. This one is a bit tricky. This is going back to isoelectric line. So if you only see a number 8 in Arabic, this R wave. Go for it. So let's now talk about each component of the QRS complex, and let's start with the Q. Q, for example, let's talk about the vector first of all. Then we will come back to the Q. It makes more sense. If we talk about the vector of the ventricular depolarization, again, we said it can have this way, many vectors, but if we take the mean vector, it will be in this direction as it's shown in the picture. So let's take 3 frontal leads and interpret it. We had lead 1 here, lead 2 here, and lead AVR here. Because it's going away from lead AVR, normally, we will see negative QRS complex. Because it's coming in the same direction of lead 2, we will have a positive QRS complex. That's why always, to see any abnormal changes in QRS complexes and P waves, always check for lead 2. Start with lead 2 because lead 2 is in the same mean vector of both atrial depolarization and ventricular depolarization as well. And lead 1 is also almost on the same direction of the vector, but it's a little bit to the left. That's why the amplitude of QRS complex in lead 2 is higher than lead 1. That's the main idea here. And the normal axis is between 7 to plus 90, even though some of the cardiologists nowadays, they say that normal axis starts from minus 30 to plus 90. But for the sake of the simplicity, let's say, we will stick only from 7 to plus 90. So if the mean vector lies between 0 to plus 90, it's called normal axis, and we will talk about this later. And let's even check the Q now as well. By the way, we said the atrial depolarization has this vector and it's going left downward. But why do we see, for example, in case of lead 1, why do we see this negative deflection? We said that in case of depolarization, anything moving towards an electrode is making a positive deflection. But here we have a negative deflection. Do you know why? Because in the beginning we said that when conduction starts from SA node to AV node, then from AV node to the bundle of phase, and bundle of phase first go to the left bundle and even first go to the septal fascicle. For example, if there's a left bundle and there's a septal fascicle normally depolarizes from left to right in this direction. That's why in the beginning of the QRS complex you will see a Q wave going downward, and it's normal. And when it's normal, we will measure it and compare it to the QRS complex. If it's less than 1/4 of the QRS complex or 25% of the QRS complex, or the R wave, sorry, we call it normal. But if it's more than that, it's abnormal. But to avoid any confusion, just remember that Q wave should be less than 2 small box. I hope that's clear. So in case of this almost 1 small box. It's normal. But if you, for example, this one is not normal. This is more than 1 small box, I guess. 2 small box, I guess. Anyway, we will see that in the future videos, especially in case of myocardial infarction. Most of the time, you will not even see an R wave. You have a P wave, then a deep QS. Especially we count the Q, the Q. The deep Q more than 2 small box represents myocardial infarction, but later we will talk about this. So we have something else also you might have heard it from here or there, that's clockwise or counterclockwise rotations. And the concept is simple. If we can just imagine heart as a clock, for example, if this is a heart and I will draw a clock around it, this 12 o'clock, 3, 6, 9. So if the heart rotates in this direction, actually the heart anatomically, I don't mean it, I will just explain it in a minute. This is called clockwise rotation. If it rotates in this direction, it's called counterclockwise rotation, and it makes sense. We have something called R wave progression. If we take the chest leads V1 to V6, normally the R wave should progress slowly and progressively. In another word, in V1, the S wave is way deep and larger than this positive small R wave we have here. But in V2, the R wave is a bit larger. In V3 is almost equal to the S wave. And V4, it has overcome the S wave. And in V5, R wave is the highest, even higher than V6. Okay, remember that it's a normal rule and it's called normal R wave progression. But what if you have, and normally the V3 and V4, we call it transition zone. The transition, it means where the R wave amplitude becomes same as or more than the amplitude of the S wave. For example, in this case, it happened in V3, it became equal. So it happened in V3, that's why it's normal. Between V3 and V4, it's normal. But what if this transition happens in V5 or V6? It happens too late. We call it clockwise rotation. And what if this transition zone happened in V2 or V1? We call it counterclockwise rotation. So this is the main idea. And let me tell you some causes. For example, normally the left ventricle is bigger than the right ventricle. That's why it attracts a lot of electricity towards itself. But what if the right ventricle, due to some lung diseases, for example, in case of pulmonary hypertension, the right ventricle becomes hypertrophied? So in this case, the right ventricle has higher masses and bigger masses of muscles. That's why it attracts more electricity towards itself. So sometimes one of the criteria even to recognize right ventricular hypertrophy is to see a big R wave in the first lead. I mean, in case of V1. So the transition zone might happen so early in V1 and V2. That's called counterclockwise rotation. So right ventricular hypertrophy can be one of the examples. But in case of clockwise rotation, when it happens too late, actually sometimes this is due to anteroseptal myocardial infarction. Why? Because the anteroseptal, which is represented by V2, V3, and V4, which we talked about it, there's an infarction there. And when there's infarction there, it means there's a loss of muscles. So electricity is not going there anymore because there's no muscles to attract the electricity towards itself. That's why it takes more time for the R wave to progress. That's why it happens in V5 and V6. This is just an example, and there are more examples to look after it. So we can have that as well, and this is just a concept I wanted to explain as well. Now let's go to the ST segment. The ST segment comes right after the QRS complex. By the way, this point where the S wave comes back to isoelectric line is called J point. Remember that we're gonna need that. If it came back to upper, for example, let's say it came back here, then we have the T wave. This point is called the J point again, and we say the J point is elevated. This is the hallmark of ST segment elevation. And again, the ST segment represents the time from the end of ventricular depolarization, which is the QRS, to the start of ventricular repolarization, because T wave represents ventricular repolarization. And remember, to say that we have ST segment elevation, there must be at least one small box elevation in all leads other than leads V2 and V3. V2 and V3, they have their own rules and criteria. In case of V2 and V3, to say there's a ST segment elevation, you should have more than two small boxes in men under 40 years old. You should have more than or 2.5 small boxes in men over 40 years old, and you should have more than 1.5 small boxes in women of any age. And the reason for this is normally there's a variation in healthy people that they have a mild elevation in ST segment in the leads V2 and V3, even in healthy people. That's why we give this criteria. If it's more than 2 in case of men under 40, then it's called ST segment elevation. You will not call a small ST segment elevation only in V2 and V3. You can see, let's say it's 0.5 millimeter, and it's only seen in V2. You will not call it ST segment elevation. That's not myocardial infarction. That's a normal variation that happens in humankind. That's all. And to say there's a ST segment depression, it should be equal or more than 0.5 millimeter in all leads other than V1 to V3, which should be more than 1 millimeter depression. Depression should come here. For example, the S come back to does not come back to isoelectric line, but below that. So that's the main idea of ST segment, which is the hallmark of myocardial infarction. In case of STEMI, we will see a ST segment elevation, and in case of non-STEMI and unstable angina, we will see an ST segment depression. And these are the criteria that we have to apply. And now, last but not the least, let's talk about T wave. T wave represents ventricular polarization, and its duration should be between 0.10 to 0.25 seconds. It's around one large box, or even a little bit more than one large box is normal. Around 6, 7 small boxes is normal. And it's about this amplitude in the limb lead, anterior lead. It should be less than one large box, 5 millimeter. In precordial leads, V1 to V6, it should be less than 2 large box. So up to that is normal. There are people that says that T wave should be 1/3 to 2/3 of the QRS complexes. You can also use that, but when you convert it to small or large boxes, it just becomes so fixed that you will not mistake it. But remember something. T waves can be inverted. In other words, it can be negative in lead 3, AVR, and V1, and it's normal. And now let me explain you why. First of all, we said in case of depolarization, in depolarization, when it goes to the same side of the electrode, it has a positive deflection on the ECG. But in case of repolarization, actually it's the opposite. If it goes to the same direction of the electrode, it will give a negative deflection. For example, let's look at this picture. We have one electrode here, there's an electrode, there's another electrode. And the repolarization is going this direction. So in case of this electrode, because the repolarization is going away from it, we have a positive deflection. And in case of this one, let's talk about this one, because it comes towards it, we have a negative deflection. Okay? And this one is perpendicular to the depolarization. We're gonna, at first, it's getting closer to it. That's why it has a negative. And then it comes back to normal isoelectric line when it reaches the same line, and it go to positive when it goes away from it. And the same applies to the others. So in another word, if you have understood depolarization, just take the opposite of it, it will be repolarization. That's why it's normal to see a positive QRS complex with positive T, because they are working in the opposite of each other. I hope we made that clear. Now, in case of the inverted waves, let's just take, for example, let's imagine the places of the leads. Let's start with lead 3 and AVR. Lead 3, we said it looks at the inferior heart, and AVR on the right side, and V1 also on the right side, but it's a chest lead horizontal, be careful. And remember, the main vector of repolarization is in this direction, towards the left. It's not the same as depolarization. Be careful, it's different. That's why if lead 3 is looking at the heart in this direction, plus 120, what you're gonna have? This lead is almost getting closer to the lead 3. That's why it's normal to see biphasic or negative T waves in lead 3. It's the same apply to AVR and lead V1. Same applies there. That's why it's normal to find negative T waves in these cases. I hope it makes sense. And now the last one is QT interval. QT interval normally it encompasses the time from the beginning of ventricular depolarization to the end of ventricular repolarization. So it includes both QRS complex and T wave and the ST segment between them. Its duration should be around 0.40 second, but actually this one is not so practical, because if we have bradycardia, normally QT interval will be longer. If we have tachycardia, normally the QT interval will be shorter. That's why we cannot use this rule all the time, but there's something that you can apply. It should be less than 40% of the RR interval. In another word, if you have two RR interval, just take the middle of them, and if the T wave ends before the middle, it's normal. If the T wave ends after the middle, it's not normal. QT is prolonged. In another word, for example, if we take, which one should we take? Let's take this one. Let's say it starts from here for the sake of the argument. 1, 2, 3, 4, 5. Well, it will be around 2.5. The middle will be here between these two RR interval. Okay, let's say this is the middle. The T wave ended before the middle of the 2 RR interval. That's why the QT interval is normal. So this is how you can apply it. Or if you stick to the time, remember, if it's more than 3 large boxes, it's abnormal. For example, you will count QT from the beginning of R to the end of the T wave. If it's more than 3 large boxes, most of the time it's prolonged. And what causes prolongation of QT interval, by the way? It can be due to acute myocardial infarction, myocarditis, bradycardia, AV blocks, head injury, hypothermia, and electrolyte imbalance. And especially focus on this part: a decreased amount of potassium, calcium, magnesium. And the main reason is about the action potential that you should remember. In case of action potential of the cardiac cells, we need potassium for repolarization, because potassium go out of the cells, and we need calcium for the plateau phase of the action potential. So if you have low potassium, it takes more time to repolarize. And in case of calcium, if you have hypocalcemia, low calcium, it takes more time for the plateau phase to happen. So in both cases, one prolongs the depolarization, the other one prolongs repolarization. That's why in both of their cases, there will be a prolonged QT interval. And sometimes this can also happen by some drugs, for example, sotalol. It's a beta blocker, and at the same time it blocks the potassium channels. That's why it can decrease the potassium and also increase the repolarization time. And as a consequence, the QT interval will be prolonged. Anyway, let's not dwell on it too much. We are always coming to the end of the video. Sorry if I guess the video became so long, but nevertheless, it deserves it. And about the axis that I said I will talk about it by the end of the video. Again, when we talk about axis, we talk about the axis of QRS complex, the depolarization. We said that we can have many vectors during depolarization, like it's numbered 1, 2, 3, 4, 5, 6, 7, 8. We can even have not 8, 80, 8,000, 8 million. It does not matter. We have a lot of vectors produced during depolarization. But when we take the mean one, we take it this side, almost around the same of number 5. Okay? And this is called mean vector that I've mentioned it here. And before coming to this table, which is so easy to understand, I want to explain more about this axis, then coming back to this table, this figure. First of all, normal axis we said should be between 0 to plus 90, but nowadays they say even up to minus 30 is normal, but we will stick to this portion 7 to plus 90. So if the mean vector lies in between 0 to plus 90 is normal. If it go to this side 0 to minus 90, we will call left axis deviation. If it comes to this side plus 90 to 180, we call it right axis deviation, and this one is extreme axis deviation if between 180 to minus 90. And for this we need two leads. Take lead 1 and take lead AVF. Why don't you take chest leads? Can you guess it? The main reason is we said chest leads, they do not give axis. They are on a horizontal side. Only the frontal leads give axis. That's why we use lead 1 and AVF. For now, forget about lead 3 and lead 1. I will explain it later. 1 and 3 we will explain. Let's start with 2. Take lead 1. Take lead AVF. In lead 1, you have positive QRS complex, okay? And in lead AVF, you have a positive QRS complex. What do you mean? Now, what's the consequence? It's normal axis deviation. It's mentioned here by number 2. If you take lead 1, which is positive, will be in this direction. Lead AVF, positive, will be in this direction. Now take what is between them, the average. It will be in this direction, and it's normal. You don't have to know the main angle. If you want to know, we will explain it in the next slide. But for now, we just need to know, is it in the normal or not? Now, let's take a negative QRS complex in lead 1 and positive in lead AVF. For example, negative QRS complex in lead 1 have this direction, going this way. And positive AVF is coming this way. So if we take both of these leads, the average will be in this direction. That's why we have right axis deviation. Now let's take lead 1 again. It's negative. So it's going this direction, left again. And take AVF. This time AVF is negative also. So it's not coming to positive 90. It will go the opposite direction, negative 90. Take the average. It will be extreme axis deviation. What if you have lead 1 is positive, again going towards 0, and lead AVF is negative, going upward minus 90, you will have left axis deviation. So that's the main thing about why do we use lead 1 and AVF. As you can see, this is a summary of what we talked about. So in another word, how do I remember this is by this way. Look at lead 1 and AVF. One is looking upward, one is looking downward. Imagine this as a couple, they are in a relationship. But now one is looking upward, one is looking downward. They are not looking at each other, so they left each other. That's why it's left axis deviation. But come to this side, they are looking at each other. One is looking up, one is looking down. They are looking at each other, so they are on the right way. That's why it's right axis deviation. And the other, you can just remember, both positive is normal, both negative is extreme. Both of them are so negative, extremely negative. Okay, this is how you can remember. And if you want to define the axis precisely to give angles to it, you will say, for example, it's plus 30, plus 60. You want to know the exact angle, not only saying it's normal or right or left axis deviation. You have to use this criteria. You will take a limb lead, the frontal lead, one of them, that the QRS complex is most nearly biphasic. Do you know what's biphasic? This is biphasic. Okay? Then the axis must be oriented perpendicularly to this lead. We said that if any wave, let's say even a P wave, if this is a P wave and it's biphasic, it means this, let's say this in lead V1, okay? Then it means that this lead look at the vector of the P wave in a perpendicular line. Perpendicular, it means degree 90, a 90 degree, okay? So you will take a QRS complex where it's perpendicular, like here. In this case, in lead 3, QRS complex is perpendicular. And we have already known from lead 1 and AVF that the axis is normal. Both of them are positive, so the axis is normal, but we want to know what is the angle of this axis. So you find the lead, the limb lead, which has a biphasic QRS complex. In this case, it was lead 3. Then you will whether minus it by 90 or you will plus it with 90. So if we plus 120 with 90, it will get into negative of extreme axis deviation of 150. Okay, but if you minus it with 90, it will be plus 30 here. Okay, and which one do we choose in this case? So now we have two options whether we're going to choose 150 as the answer or plus 30 as the answer. We choose the answer based on the axis. If the axis is normal, as we said it's normal, both of them are positive, lead AVF and lead 1, you will choose the positive one that's lying in the normal side. So in this case, the patient has a normal axis with the angle of plus 30. That's everything. We are done with ECG. Now I will just tell you some steps that you can use it when you see an ECG paper. How do you approach it? And we are done with this video. First of all, you really need to confirm the patient details, name, age, all of that stuff that you need. Then you need to check the calibration and paper speed. Please start with checking calibration and paper speed. Because, for example, in my case, I'm in Russia, and most of the time they use the ECG on paper speed of 50 millimeter per second. And trust me, a lot of time I have said this patient has left bundle branch block because I thought the QRS complex is widened, but it turned out to be normal because I didn't look at the speed. I was just thinking about the normal standard ECG, which is on 25. So you really have to pay attention to this. Next step in the ECG is to evaluate for the rhythm. Is it regular or irregular? If regular, you can immediately count the heart rate. If it's four large boxes, you say it's 75. So you can do that. But if it's irregular, delay it for later because it takes time to calculated, you need a calculator, so you don't have to waste time at that particular period. And even nowadays, most of the ECGs, they count the heart rate as well. And the next step, you will analyze the P wave. Are P wave present or not? Because it's really important. And are wave present, and are they followed by QRS complex every time or not? Because there can be some type of AV blocks. You have a P wave, but you don't see a QRS complex, or vice versa. Okay, so you really have to be careful. Is each P wave followed by a QRS complex or not? So if you have a collaboration between these two, rhythm and P wave, you can make some judgments. By the way, already you can make some conclusions. For example, if P wave present and the rhythm is normal, you can immediately say this patient is in normal sinus rhythm. And let's take the opposite of it. If there's no P waves and the rhythm is irregular, and we call it irregularly irregular, you can say it's atrial fibrillation, and it will turn out to be right. So you can already make a step into advanced ECG from understanding the basics. So that's this. And coming to the PR interval, next step, you'll check the PR interval. Is it, from here, PR interval, is it prolonged or not? If it's prolonged, it shows AV blocks. If it's shortened, less than 3 small blocks, it shows accessory pathways, as in case of Wolff-Parkinson-White syndrome, which we will explain it later, not in this video. Then you will assess the QRS complex. It should be less than 2.5 small box. If QRS complexes are narrow, there is no problem. And when it comes to QRS complex, we only have problem with wide QRS complex or super high QRS complexes, those that have a high amplitude that we can immediately notice some problems. And in case of wide QRS complexes, most of the time it turns out to be bundle branches blocked. Then you will measure the QT interval. Some people move directly to ST, so it's up to you. This is personal. Which one do you choose? It's up to you. But you can start with QT, like going step by step. You will measure the QT. If it's prolonged, there might be some sort of imbalances, electrolyte imbalances that we talked about, all the reasons, so you can check them out. And then you will go to ST segment. Is there any ST segment elevation or depression? You will check for myocardial infarction if there is elevation. And you will also analyze the T wave. If the T wave is so high, peaked T wave, almost sometimes higher than the QRS complex, it's due to hyperkalemia, high amount of potassium. Then another thing you can do is to compare it with previous ECGs. You can also do this because there can be some changes that are new, and this can indicate some underlying diseases. And you can also integrate it with clinical context. For example, the patient has chest pain, you will look for ST segment elevation, this kind of stuff that will help you. Last but not the least, let's do an ECG. Let's read it and apply the steps. First of all, you'll check the patient name, the details, everything. You'll check calibration. We have calibration here. For example, let's take this one. It's 2 large box, okay? This one is 2 large box, which is 10 millimeter, which is normal, the normal standard. And the speed here is not written, but most of the time it will be written in the left corner, 25 millim per second, or it will be written down below. And this is normal. Then the first thing, is it regular or not? Let's check. Always take lead 2 and take the one that has a long strip. Okay, for example, this one, the RR interval is 4 large box. This one is also 4. Actually, this is not 4, this is 3 and almost 4. This one also the same. If you count it, for example, from the tips, it's almost the same. Let's count this one also, 3 and also almost 4. So in small boxes, it will be around 19 small boxes, all of them 19. So in this case, we can say it's regular. So we decided it's regular. The next thing is to look for P waves. That's followed by QRS complex. P wave, QRS, P wave, QRS, P wave, QRS. Now let's even go to another lead. P wave QRS, P wave QRS. So that's almost all P wave QRS. So we can say P waves present. So we have regular rhythm, P wave present. We can say we have a normal sinus rhythm. Already we can decide on that rhythm. And normal sinus rhythm, by the way, it means the rhythm, the conduction system starts from the SA node and it's normal. That's what it means, normal sinus rhythm. Then let's move to the next step. We have the PR interval. It will start from here to here, but let's be more in detail. This is almost on the line. So in this case, we have 1, 2, 3, 4. 4 small boxes, normal. We said between 3 to 5 is normal. So normal PR interval. Then we can go to the QRS complex. The QRS complex is almost two small boxes because you will count till it comes back to isoelectric line. It's two small boxes, normal. Then you will move to, for example, you can move to ST segment. The ST segment, you have to check almost not every lead. For example, we said lead 1, lead AVL, V5, V6 represents the left lateral side of the heart. You don't have to check all of them. Check one or two, that's enough, because they all look at the heart from left side. For example, let's look at V5. The ST segment is on the same isoelectric line. So there's no elevation, there's no depression, it's normal. Lead 1 is the same. Okay, now let's go to the inferior leads, lead 2. For example, we might see some sort of elevation, but it's even more than 0.5. So it's not counted. It's almost not elevation, by the way. It's totally normal because you have to take this one. So it's normal. It's totally normal. And to check even more, let's take lead 3 because lead 2, 3 AVF, look at the inferior side. Lead 3, normal. Lead AVF, normal. So it means it's normal. Now let's come to the anterior septum. You can take V1, normal, V2, normal. This one is T wave, by the way. V3, there's some sort of changes, but we said V2 and V3 can be variable a little bit. If we see a little bit of changes only in them, it's normal. So ST is normal. Now let's go to the T wave. T wave, let's start with lead 2. It's normal, normal. Mainly look for inverse T waves. For example, we have inverse T wave in V1. Is it normal? Yes, it's normal. V1, lead 3, HVR can have inverted T waves. But in others, they're all positive and normal amplitude and stuffs. Everything is normal. So QT interval, let's take two RR interval. For example, this one is, we said 19 small, but let's take around 10 two large boxes as the middle between two RR interval, okay? The T waves comes before the middle of the RR interval. That's why the QT interval is normal. So this ECG is totally normal. Normal sinus rhythm with no abnormality. And we came to the end of the ECG video. Remember, every heartbeat tells a story, and within its rhythm lies the melody of life. Nevertheless, to access this PDF, you can join my Telegram channel, and also there are many other ECG files and tutorials. You can get benefit of it. Wassalamu alaikum wa rahmatullahi wa barakatuh.